You're looking at the MRI of a 52-year-old heavy manual laborer, massive retracted posterosuperior rotator cuff tear. It is definitively irreparable. The Goutallier grade is a solid 4. I mean, that muscle belly is almost entirely replaced by fat, and the tendon edge is retracted so far, medially it's practically hugging the glenoid neck.
A truly frustrating presentation for any orthopedic clinic.
Right, and they are sitting there presenting with unremitting, severe night pain and a profound loss of active elevation. But here is the critical variable that makes your heart sink just a fraction when you look at the plain radiographs. There is no significant glenohumeral arthropathy. The joint space is absolutely perfect.
Yeah, it's a Hamada grade 1, maybe a mild 2 at absolute most.
Exactly. So what do? You cannot offer them a reverse total shoulder arthroplasty. They are simply too young and too active. And the complication profile for a primary reverse in a 52-year-old bricklayer is a nightmare waiting to happen.
It's an absolute non-starter. You put a reverse in that patient, and you're guaranteeing catastrophic component wear or loosening within a decade.
Spot on. And a partial repair won't give you the biomechanical stability you need. A tendon transfer might leave them with unpredictable pain relief. So 10 years ago, the answer seemed completely obvious. Superior capsular reconstruction. But today we really need to talk about whether we've all been sold a highly sophisticated biological doorstop.
It is the classic orthopedic catch-22, isn't it? You're staring at a joint that is mechanically failing but biologically too pristine to replace, sitting inside a patient whose functional demands vastly exceed the capacity of our standard salvage procedures.
And the frustration is palpable because you know whatever path you choose is fraught with compromise. For the past decade, superior capsular reconstruction, or SCR, has totally dominated shoulder society meetings, operative technique urinals, and symposiums as the purported silver bullet for this exact scenario.
It really has. When it first hit the scene, it was heralded as an absolute game changer. It promised to restore the native kinematics of the shoulder, relieve the impingement pain, and, most importantly, preserve that pristine native joint space.
But as the medium to long-term data slowly trickles in, the orthopedic community is beginning to ask some incredibly difficult questions. So that is the exact mission of today's deep dive. We are going to critically evaluate superior capsular reconstruction from the ground up.
Which is absolutely necessary right now. We are firmly in the phase of critical reappraisal with this procedure.
Right. We need to dissect the biomechanics, debate the graft options, walk through the brutal friction of the arthroscopic technique itself, and nail down the absolute make-or-break patient selection criteria. So let's start at the absolute genesis of this technique. We have to go back to 2013 to Dr. Terahisa Mehata's landmark cadaveric paper.
A genuinely brilliant piece of foundational research.
It was. Before this publication, the superior capsule was essentially an anatomical afterthought. It was functionally lumped in with the supraspinatus tendon. Mehata isolated it and proved its biomechanical necessity. So walk us through the exact biomechanical blueprint that Mehata laid out, because if we don't understand the native kinematics, we really have no business trying to reconstruct them.
Absolutely. The absolute brilliance of Mehata's work was shifting the orthopedic paradigm away from viewing the rotator cuff purely as a set of dynamic movers and refocusing our attention on the static restraints. For decades, we have understood the dynamic force couples of the shoulder.
Like the transverse force couple.
Right, the subscapularis anteriorly balancing the infraspinatus and teres minor posteriorly. And then, crucially for this specific discussion, you have the coronal force couple.
Which is where the deltoid is firing and trying to pull the humerus vastly superiorly, and it's balanced by the inferior rotator cuff, pulling it down and basically compressing the head into the glenoid concavity.
Precisely. But when you have a massive, irreparable supraspinatus and infraspinatus tear, that coronal force couple is completely obliterated. The deltoid fires, and without that opposing inferior pull, the humeral head simply translates proximally.
Then just rides straight up.
Straight up. What Mehata and his team did was rigorous sequential cadaveric testing. They demonstrated that the superior capsule itself, which, is a distinct measurable anatomical structure attaching from the superior glenoid tubercle to the greater tuberosity, actually acts as the primary static restraint to this superior translation.
So it's not just the tendon doing the work.
Exactly. It is not just the tendon. When the superior capsule is compromised or entirely lost alongside the rotator cuff, the humeral head rides up unchecked and physically impacts the undersurface of the acromion.
And that bone-on-bone or bone-on-ligament impaction is the source of the unremitting pain for these patients.
Yes, it creates a massive kinematic mismatch. The deltoid is contracting, but its energy is entirely wasted on driving the humerus into the roof of the shoulder rather than elevating the arm. Mahata's rationale was beautifully simple in its logic. If the tendon is gone and cannot be repaired, reconstruct the static restraint.
You build the wall.
Right. Anchor a thick, robust graft from the superior glenoid to the greater tuberosity to physically block that superior translation. By doing so, you restore the stable fulcrum, allowing the deltoid to actually act upon the arm and elevate it.
Let's anchor this with an analogy for you listening. Think of the intact superior capsule as the vaulted ceiling of a grand room. The humeral head is the heavy furniture inside. As long as that vaulted ceiling is intact, the room functions perfectly.
A very apt way to visualize it.
Right, but in a massive rotator cuff tear, that ceiling collapses. When the deltoid fires, it's like a localized earthquake. The furniture is thrown violently upwards, crashing directly into the roof, which is the acromion. Mahata's SCR is essentially bringing in specialized scaffolding to artificially rebuild that vaulted ceiling so the humerus stays exactly where it belongs.
That is an exceptional visualization of the structural mechanics at play. By restoring that ceiling, you recreate a stable center of rotation. You allow the remaining intact cuff, usually the subscapularis anteriorly, and the lower half of the infraspinatus or teres minor posteriorly, to effectively compress the head against the glenoid.
While the deltoid does its actual job.
Exactly. Meanwhile, the deltoid can once again efficiently elevate the arm without losing its kinetic energy to that superior translation.
Okay, I like the theory, but here is where I want to push back on the fundamental premise of the operation. Let's be rigorously honest about what we are doing in theater. Is this procedure truly reconstructing the anatomy in a biological, kinematic sense?
That is the core of the debate right now.
Because, reconstruction implies a return to native physiological function. Or are we just performing an incredibly elegant, arthroscopically demanding insertion of a biological doorstop? Are we truly restoring the physiological force couples, or are we just artificially wedging a thick piece of tissue in the subacromial space to artificially depress the humeral head?
It is a totally valid challenge. You are right. The term reconstruction is arguably a misnomer. An SCR graft does not contract. It has no motor end plates. It is not dynamic. It is fundamentally a static tether.
So it literally is just a spacer.
Well, it acts as a spacer, but the biomechanical data suggests its effect is actually more profound than just a passive wedge. By physically tethering the humerus to the glenoid, the tension of the graft actively resists superior migration throughout the entire arc of motion.
As long as it's tensioned correctly.
Right. When it is tensioned correctly, it prevents the abnormal kinematics that lead to the pain and dysfunction. It essentially forces the dynamic muscles, the deltoid and whatever intact cuff remains, to operate within their optimal length-tension relationships again.
I see.
So while the graft itself is a static structure, its secondary effect on the dynamic function of the shoulder elevates it beyond a mere spacer. It rehabilitates the surrounding musculature by giving them a stable platform to work from.
Which brings us perfectly to the most contentious variable in this entire procedure. If we are relying on this newly constructed vaulted ceiling to withstand the tremendous repetitive superior shear forces of the deltoid muscle, a muscle that fires thousands of times a day, every single time the patient lifts a cup of coffee or reaches for a door, the material we choose to build that ceiling is paramount.
The material is absolutely everything.
Because if the material is weak, the ceiling collapses again. Let's transition into the great graft debate. We're essentially looking at three main options here: fascia lata autografts, dermal allografts, and synthetic patches. Let's start with Mahata's gold standard.
The evolution of our graft choices reflects an ongoing, frustrating struggle to balance biomechanical strength with biological incorporation and patient morbidity. Mahata established the gold standard, which is the fascia lata autograft.
From the patient's own leg.
Yes. In his original technique and in his subsequent reported series, which boast incredible long-term survivorship, Mahata utilized a folded fascia lata graft harvested from the patient's own thigh.
And biologically, that makes total sense, doesn't it?
Absolutely. The clinical literature, particularly from the Japanese cohorts, demonstrates exceptional healing rates and very low graft failure rates with this approach. The autograft provides native collagen, intrinsic fibroblasts, and a biologically active scaffold that incorporates beautifully into the bleeding bone bed at both the glenoid and tuberosity footprints.
It is your own tissue.
Yep.
Your body recognizes it and integrates it rapidly.
Precisely. It's living tissue.
But the catch with the fascia lata autograft is massive,
Yeah.
and it is entirely outside the shoulder. We're talking about severe donor site morbidity. Let's be clear about what this harvest actually entails for the patient.
It's not a minor incision.
Not at all. To get a strip of fascia lata large enough to be folded over on itself twice or three times to create a robust 6 to 8 millimeter thick construct, you are making a massive incision on the patient's lateral thigh. You are stripping out a huge section of their iliotibial band.
Yes, and you are subjecting the patient to potential muscle herniation, massive postoperative hematomas, seromas, and profound lateral thigh pain.
Often, the patients wake up and complain entirely about their leg, completely ignoring the shoulder surgery they just had. You are creating a secondary, brutal rehabilitation process just for the harvest site.
The donor site morbidity cannot be overstated. It is the primary reason the procedure faced such resistance outside of Japan initially. I mean, for a patient who is already facing a grueling 6-month shoulder rehabilitation, adding a painful leg recovery, a limp, and a massive scar is a huge deterrent.
Which naturally leads us to the alternatives.
Exactly. This exact clinical dilemma, the desire for the biomechanical outcome without the thigh morbidity, paved the way for the explosive rise of the dermal allograft, heavily championed by surgeons in North America.
By using a cellular human dermal matrix, commercially known as Arthurflex, or similar decellularized product surgeons, can completely spare the patient the secondary harvest site.
Right, you pull it out of a packet, rehydrate it on the back table, and the operation becomes localized entirely to the shoulder.
But you don't get something for nothing in orthopedics. The dermal allografts solve the morbidity issue beautifully, but the literature shows a stark, uncomfortable contrast in structural outcomes.
It's a very significant trade-off.
The recent systematic reviews highlight that dermal allografts have a significantly higher clinical failure rate. And we aren't just talking about the anchors pulling out of the bone. We are talking about higher rates of mid-substance graft tearing or more insidiously elongation over time compared to the fascia lata outcomes. Why does the allograft fail where the autograft succeeds?
The failure mechanisms of dermal allografts are fascinating and fundamentally biological. Because it is in a cellular matrix, meaning it has been stripped of all donor cells to prevent an immune response, it relies entirely on the host's biology to populate the graft.
It needs the patient's local fibroblast and vascular network to physically invade the matrix.
Exactly, a process we call creeping substitution. The graft essentially serves as a passive, empty apartment building.
And you're just hoping the host cells actually move in?
Right. If the host's biology is sluggish, perhaps they are a smoker or diabetic or just older, or if the mechanical forces of the deltoid overwhelm the graft before full cellular incorporation occurs, the dermal allograft tends to elongate.
So it doesn't necessarily snap in half.
Not usually. It doesn't necessarily tear. It stretches out sort of like an old rubber band. At a microscopic level, the collagen fibers are experiencing micro tears and plastically deforming because there are no active fibroblasts laying down new type 1 collagen to repair the daily wear and tear.
And once it elongates by even 5 or 6 millimeters, it completely loses its tension.
Precisely. The humeral head migrates superiorly again, the impingement returns, and the mechanical benefit of the SCR is completely lost, even if the graft technically remains solidly attached to your suture anchors.
And this brings up a crucial biomechanical pearl regarding the architecture of whatever graft you choose, whether it's from the thigh or from a freezer. Thickness matters immensely. The literature explicitly points out that a graft thickness of 6 to 8 millimeters is optimal.
That is the absolute golden rule of this procedure.
Walk us through the physics here. Why is that specific window so critical? Because if we are worried about the deltoid tearing the graft, why not just put in a massive bulletproof 12 millimeter graft to ensure it never ruptures? Or conversely, why not a 3 millimeter graft to make rolling it up and passing it down an arthroscopic cannula infinitely easier?
That 6 to 8 millimeter window is the absolute biomechanical sweet spot. If you use a graft thinner than 6 millimeters, say a single layer of fascia or a very thin dermal patch, the biomechanical studies clearly show it lacks the ultimate tensile strength to resist the superior pull of the deltoid.
So it will invariably elongate or undergo catastrophic structural failure under physiological loads within months.
Yes, thin grafts fail structurally.
What about the thick grafts then?
If you use a graft thicker than 8 millimeters, you run into the severe problem of overstuffing the joint. You effectively create a mechanical block to elevation. You are inserting too much physical volume into the subacromial space.
Which obviously restricts motion.
It restricts motion, but worse, it overtensions the joint, restricts the natural rotational kinematics, and
Mhm.
paradoxically increases the tension on the suture anchors at the glenoid and tuberosity to astronomical levels.
Because the humeral head is basically acting as a cam, and as it rotates, it's
Ah,
just prying the anchors right out of the bone.
exactly. A graft that is too thick will essentially pry itself off the bone during a normal arc of motion. The pull-out forces exceed the strength of the cancellous bone. This 6 to 8 millimeters perfectly replicates the native superior capsule's capacity to restrain translation without impeding rotation or overloading the fixation points.
I want to play devil's advocate here and challenge the risk-benefit ratio, looking at it through the lens of our 52-year-old laborer we discussed at the top of the show.
Go ahead.
If the primary overarching goal of superior capsular reconstruction is pain relief and the restoration of functional elevation so this person can get back to work, is it truly justifiable to subject that patient to the significant, painful donor site morbidity of a fascia lata harvest?
Yeah.
Just to lower the statistical radiographic risk of graft failure.
It's the central ethical question of the graft debate.
Right. Because think about it. If a dermal allograft gives them 5 to 7 years of pain-free function before it inevitably stretches out, isn't that a better trade-off for the patient's immediate quality of life
Yeah.
compared to dealing with a massive thigh incision?
You have just articulated the exact philosophical divide currently splitting the global shoulder community. The North American perspective largely aligns with your point. Spare the morbidity, use the allograft, accept the higher graft failure rate because clinical failure does not always perfectly correlate with radiographic failure.
We see that all the time. Patients with stretched grafts who feel fine.
We see many patients with stretched dermal allografts on an MRI who still report highly satisfactory pain relief. However, the counter-argument, heavily favored by Mejada and the international surgeons adopting his strict criteria, is that we are performing a structural reconstruction.
And if the structure fails?
If the structure fails, the joint kinematics revert, the cartilage begins to wear abnormally, and you have not altered the natural history at all. In a 52-year-old heavy laborer who needs their shoulder to lift bricks, an elongated dermal allograft will fail them clinically much faster than it would a sedentary 70-year-old.
That makes perfect sense. The mechanical demands are just too high.
Exactly. In that specific high-demand demographic, many argue the temporary thigh morbidity is a very small price to pay for a robust, permanent biological joint preservation.
That perfectly highlights the tension between biological perfection and clinical pragmatism. Now, let's assume we have had that tough conversation in the clinic. We have selected our graft. We have our perfectly sized 8-millimeter thick biological scaffold resting in saline on the back table.
The fun part begins.
Exactly. The focus now shifts from the material to the execution. We are moving from the graft prep station to the arthroscopic monitor. Let's not sugarcoat this for everyone listening. This procedure is notoriously, brutally demanding. It is not a standard double-row rotator cuff repair.
Not even close. It is widely considered one of the most technically challenging procedures in the entire arthroscopic repertoire. When Mejada first introduced it, the operative times were daunting, often 3 to 4 hours.
The friction of the procedure is immense.
The friction is unbelievable. Managing a massive, stiff graft through narrow arthroscopic cannulas, orienting it correctly in the tight subacromial space while your fluid pressure drops, and achieving secure flush fixation on both the glenoid and the humerus requires an exceptional level of spatial awareness and technical proficiency.
Let's discuss the arthroscopic refinements that have actually made this procedure feasible for surgeons outside of a few highly specialized academic centers. Because in the early days, surgeons were just creating a spaghetti tangle of sutures in the subacromial space.
Oh, it was a total mess of suture management initially.
The evolution here was heavily driven by surgeons like Stephen Burkhardt. How have the techniques evolved to make this highly complex, time-consuming procedure more reproducible?
The entire technical evolution has been focused on simplifying graft passage and optimizing the tensioning. As you mentioned, the early days were a nightmare of suture management. You have 4 to 6 anchors, each with multiple suture limbs.
Trying to tie knots blindly in the subacromial space over a thick piece of tissue is just an exercise in complete frustration.
It really is. Burkhardt and his colleagues introduced brilliant modifications to overcome this, most notably the double pulley technique.
Stop right there and explain the exact mechanics of that double pulley system for the listener, because it really changed the landscape of the operation. How does it eliminate the knot-tying nightmare.
Essentially, rather than tying knots in the joint, you place your medial anchors into the superior glenoid first. You then pass all those suture limbs out through a single large lateral cannula.
Okay, so they're all outside the body.
Yes. On the back table, you pass these specific sutures through the medial edge of your graft. The brilliance of the double pulley is that by utilizing a specific sliding knot configuration or knotless anchor mechanisms, you connect the suture limbs.
Right.
You then pull on the free ends outside the body, and you use the sutures themselves as a pulley system to literally parachute the graft precisely down the cannula and directly onto the glenoid footprint.
So it just slides down the rails directly onto the bone.
Exactly. It ensures the graft sits perfectly flush against the bone without folding on itself or rotating.
And achieving that flush footprint is everything for the biology, isn't it? If there's a gap, or if the graft is buckled, synovial fluid gets between the graft and the bleeding bone bed, and it will never, ever incorporate.
Precisely. The goal is what we call the trampoline effect. You want taut, flat, sealed surface. Once the medial side is secured flush to the glenoid, the lateral side is secured to the greater tuberosity using a speed bridge or equivalent knotless construct.
But the crucial refinement here, the step that really dictates the success of the entire operation, is the arm position during that lateral fixation.
Yes. You must tension and secure the lateral anchors with the arm held rigidly in approximately 20 to 30 degrees of abduction.
Why specifically 20 to 30 degrees? What happens if an inexperienced surgeon tensions it with the arm resting flat at the patient's side?
If you tension the graft with the arm at 0 degrees of abduction, the graft will be excessively tight. The moment the patient wakes up and attempts to elevate their arm, the graft will act as an absolute tether.
It'll just lock the shoulder.
It will either restrict motion entirely, causing a severe iatrogenic stiffness, or the sheer force of the deltoid trying to lift the arm will rip the anchors straight out of the glenoid. It's basic geometry.
And conversely, if you tension it while the assistant is holding the arm way up at 60 degrees of abduction,
Then the graft will be far too lax when the arm returns to rest at the patient's side. It will be flaccid, rendering it completely incompetent as a superior restraint. The humeral head will just migrate right past it.
so it has to be 20 to 30 degrees.
20 to 30 degrees of abduction provides the perfect biomechanical equilibrium. It is taut enough to prevent superior migration at rest, but with enough inherent excursion to allow full, unhindered elevation.
It is a remarkable feat of arthroscopic engineering. But here's the brutal reality check for anyone listening. Even if a surgeon executes the procedure flawlessly, even if they utilize the double pulley technique perfectly, achieve a beautiful trampoline effect with an ideal 8mm fascia lata autograft tensioned perfectly at 30 degrees of abduction,
They can still fail.
that entire construct will still fail catastrophically if it is placed into the wrong shoulder. Which leads us to the absolute make-or-break variable of this entire discussion, patient selection.
You can have perfect surgery, pristine knotless anchors, and perfect biological materials, but biology and biomechanics will never be fooled. Patient selection is the ultimate, non-negotiable determinant of SCR success.
You cannot cut corners here.
If you compromise on the indications, if you try to stretch the criteria to fit a desperate patient, the procedure will fail. The literature is completely unanimous on this point. There is a very specific, narrow physiological profile required for this graft to function.
Let's establish that profile clearly right now. Give us the definitive clinical pearl regarding who actually benefits from an SCR.
The absolute core principle is this. SCR works best, and arguably only works, in patients without significant glenohumeral arthropathy, and crucially, with a fully functional deltoid and an intact anterior force couple.
Let's break those down, starting with the deltoid, because I think this is where a lot of confusion lies in the clinic. We need to differentiate heavily between a patient with a functional deficit secondary to pain or altered mechanics and a patient with true pseudoparalysis.
Because they can look very similar when they walk into the examination room.
Exactly. This distinction is paramount, and getting it wrong leads to surgical disaster.
Pseudoparalysis implies a total inability to actively elevate the arm above 90 degrees, despite having a full, free, passive range of motion. This is typically due to profound mechanical failure or neurological compromise of the deltoid or the remaining cuff.
Think of a patient with a previous axillary nerve injury, or a deltoid that has been detached and failed to heal from previous open surgeries.
Right. If a patient has true pseudoparalysis and the deltoid is physiologically exhausted or neurologically impaired, an SCR will fail 100% of the time. The SCR does not lift the arm. The SCR merely provides the stable fulcrum.
The deltoid is the engine.
Exactly. If the engine is dead, providing a better fulcrum will not restore elevation.
Conversely, a functional deficit is when the deltoid is healthy, it is innervated, and it genuinely wants to fire. But it cannot overcome the mechanical disadvantage of the absent superior capsule.
The energy of the deltoid contraction is wasted entirely on pulling the humerus up into the acromion, causing massive impingement pain, rather than actually rotating the humerus upward.
So in a functional deficit, the moment you surgically restore the superior capsule and physically prevent that proximal migration, the deltoid's force vector is redirected back to its normal physiological plane.
The fulcrum is restored, and the patient can suddenly elevate their arm again. Furthermore, the anterior static and dynamic restraints must be intact. The subscapularis is absolutely vital here.
What happens if the subscapularis is gone?
If you have a massive tear that extends anteriorly and involves the entirety of the subscapularis, the transverse force couple is destroyed. An isolated superior graft cannot compensate for a massive anterosuperior defect. The humeral head will simply escape anteriorly, and the graft will fail.
I want to ask an incisive clinical question that challenges the necessity of the surgery itself. If we are stating definitively that the ideal candidate must already possess a perfectly functional, strong deltoid and a completely intact subscapularis, why subject them to such a massive, morbid 3-hour reconstruction at all?
It's a fair point to raise.
If the engine is healthy, why not just rely on aggressive, specialized physiotherapy? I'm talking about a dedicated anterior deltoid re-education program to maximize that existing deltoid function and compensate for the torn cuff. Surely conservative management should work if the deltoid is fine.
It is a brilliant question, and you are absolutely right in terms of the initial treatment algorithm. A structured, intensive anterior deltoid re-education program should absolutely be the first line of treatment for these patients. It is mandatory.
You always try physio first.
Always. Many patients, particularly older ones, can compensate beautifully with 12 weeks of targeted physiotherapy. But the SCR is explicitly reserved for those who fail this exhaustive conservative management.
And why exactly do they fail?
Because of the concept, the kinematic mismatch and unremitting pain. Even with a spectacularly strong deltoid, if the humeral head is continuously crashing into the highly innervated acromion and the coracoacromial ligament, the pain is excruciating.
And that severe pain inherently inhibits deltoid function. You cannot out-rehab pain inhibition.
You really can't. Furthermore, without the superior capsule, the lever arm of the deltoid is fundamentally shortened. It has to work exponentially harder to achieve the same degree of elevation.
Which just tires it out.
Over time, this kinematic mismatch leads to rapid muscle fatigue, chronic night pain, and the accelerated wear of the superior glenoid and acromion. The SCR becomes necessary when physiotherapy simply cannot overcome the mechanical reality of the superior escape.
And that mechanical reality ties directly into age and the absence of arthropathy. We want a patient young enough to require heavy, repetitive use of the shoulder, but with cartilage healthy enough to justify preserving the joint.
Yes, the cartilage status is the final gatekeeper.
If they already have a hemotic grade 4 or 5, where the articular cartilage is completely gone, the joint space is obliterated, and the humerus has already remodeled the acromion into an acetabulum. Preserving that joint is a futile, misguided endeavor.
Exactly. In the presence of established arthropathy, the pain generator is no longer just the subacromial impingement, it is the arthritic glenohumeral joint itself. An SCR will not cure bone-on-bone arthritis.
The graft might depress the head, but the joint will still hurt.
In those cases, regardless of whether the patient is 55 or 85, the algorithm shifts decisively away from biological preservation and directly toward arthroplasty.
Knowing precisely who the ideal candidate is forces us to confront the patient who does not perfectly fit this incredibly narrow profile. And this brings the SCR face-to-face with the rest of our surgical armamentarium. We need to navigate the alternatives algorithm.
Because SCR isn't the only option available.
No, for a long time, SCR was treated as the only biological option for the massive irreparable tear. But we have partial repairs, tendon transfers, the relatively new subacromial balloon spacers, and of course, the reverse total shoulder arthroplasty.
Let's systematically compare SCR to these alternatives, because this is where the clinical decision-making gets really difficult.
It's a complex decision tree. Let's start with the biological alternatives. Tendon transfers. specifically the lower trapezius or the latissimus dorsi transfers.
The comparison between an SCR and a tendon transfer perfectly highlights the fundamental difference between static and dynamic reconstruction. As we established at length, the SCR is a static tether.
While the tendon transfer is dynamic.
Exactly. A tendon transfer, heavily pioneered for these specific massive tears by surgeons like Bassem El-Hassan using the lower trapezius, attempts to restore a dynamic force. You are surgically rerouting a functioning innervated muscle, often extending it with an Achilles allograft, to recreate the external rotation and head depression historically provided by the native infraspinatus.
So why choose an SCR over a lower trapezius transfer? When do you deploy one versus the other?
It depends entirely on the primary functional deficit the patient presents with. If the patient's primary overriding complaint is a profound lack of external rotation, they have a massive external rotation lag, a positive hornblower sign, they can't reach their face to eat, and their arm is stuck in internal rotation, an SCR will not fix that.
Because the SCR only blocks superior translation. It does not actively externally rotate the arm.
Exactly. In that scenario, a dynamic tendon transfer like the lower trapezius is vastly superior because the line of pull perfectly mimics the infraspinatus.
But what if external rotation is okay?
However, if the primary issue is superior escape, severe impingement pain, and a loss of active forward elevation, but with reasonably preserved external rotation, the SCR is structurally much better designed to address that specific kinematic failure.
That makes perfect physiological sense. Match the procedure to the specific vector deficit. Now let's look at the simpler, vastly quicker end of the spectrum, the subacromial balloon spacer.
The in-space balloon.
Right. This is essentially a biodegradable polyl-lactide spacer inserted arthroscopically over the cuff defect and inflated with saline. To use an analogy, if the SCR is meant to be the permanent load-bearing structurally integrated into the walls of our collapsed room, the balloon spacer is merely an inflatable temporary car jack used to lift the ceiling just long enough to do some quick repairs.
That analogy is highly accurate. The balloon spacer provides a strictly temporary biomechanical assist. It is an interpositional device that physically depresses the humeral head, reduces the subacromial friction, and theoretically allows the deltoid to rehabilitate in a more mechanically advantageous position without pain inhibition.
So the critical difference is biology and longevity.
Yes, the balloon is biodegradable. It predictably resorbs and disappears within 12 months. It relies entirely on the premise that a year of temporary spacing is enough time for the patient's surrounding musculature to permanently adapt, strengthen, and compensate for the torn cuff. The SCR, conversely, is designed to be a permanent structural integration.
But this is where we must bring in the vital, often uncomfortable, real-world variable that dictates so much of what we do in theater: health economics and cost-effectiveness.
It's the elephant in the room.
A thick, high-quality dermal allograft matrix for an SCR is exceptionally expensive. It can cost thousands of pounds just for the patch. You're using 4 to 6 premium knotless anchors. The operative time is often double that of a standard repair, consuming massive theater resources.
Not to mention the post-op care.
Right, the rehabilitation requires months of specialized physiotherapy. Compare that to a balloon spacer, which takes 15 minutes to deploy, or even a primary reverse arthroplasty, which has a highly predictable implant cost and a highly predictable rapid outcome.
It's a tough sell to administrators.
Weighing the massive financial and biological cost of an SCR against these alternatives is a major point of contention, especially in resource-constrained systems.
The cost question is undeniably one of the heaviest weights on the scales against SCR, particularly in single-payer healthcare systems like the NHS. When you factor in the sheer cost of the dermal patch, the array of anchors, the extended theater time, and the intensive protracted postoperative physiotherapy, an SCR represents a massive financial investment per quality-adjusted life year, or QALY.
And the value of that QALY depends entirely on the graft surviving.
Exactly. If the procedure predictably lasted 20 years in every patient, the cost-effectiveness would be unquestionable. But if we are expending that massive amount of resources on a procedure that, based on current dermal allograft data, may structurally elongate or fail in 3 to 5 years, health economists and hospital administrators rightly question whether the temporary biological preservation is worth the premium.
Especially when an early reverse arthroplasty provides excellent, reliable pain relief at a lower overall episode of care cost and a vastly faster return to function.
Exactly.
The ultimate test of that cost-effectiveness and the true comparative value of the procedure lies entirely in the postoperative reality. Let's move to the medium-term outcomes. Because the biology needs time to incorporate. The immediate postoperative phase is absolutely critical. We can't just fix them and send them back to work.
Not at all. The rehabilitation protocol is arguably as important as the surgical execution itself. You cannot rush biology. After an SCR, the patient is looking at a minimum of 6 weeks of strict, continuous immobilization in an abduction sling.
6 weeks is a long time for a working patient.
It is, but the graft must heal at the bony footprints, the superior glenoid, and the greater tuberosity before it can withstand any mechanical load. If you initiate active motion too early, the micromotion at the graft-bone interface will disrupt the ingrowth of Sharpie's fibers, preventing creeping substitution and leading to a fibrous non-union and early catastrophic failure.
It has to be protected.
It is an incredibly slow, deliberate process of passive range of motion starting at 6 weeks, eventually progressing to active-assisted, and finally, strengthening is only introduced well after the 3-month mark. It tests the patience of both the surgeon and the patient.
But let's confront the hard data. We have moved past the honeymoon phase of the initial publications from a decade ago. We now have robust medium-term failure rates, and the modes of failure are incredibly telling. How and why are these grafts failing when we look at them 5 years out?
The failure modes generally fall into 3 distinct categories. First is failure of incorporation, where the graft simply never heals to the bone, often pulling off the glenoid anchors within the first few months.
Which is devastating so early on.
It is. This is usually a biological failure or a failure of achieving that flush trampoline effect we discussed. Second is catastrophic mid-substance tearing, usually due to a traumatic event, a fall or heavy lifting, before the graft has fully matured.
And the third.
But the third and most insidious mode of failure, particularly prevalent with dermal allografts, is elongation. The graft heals beautifully to the bone, the anchors are solid, it does not tear, but under the relentless daily cyclic loading of the deltoid, the acellular matrix stretches.
It just slowly gives way over time.
Yes. It elongates by 3, 4, maybe 5 millimeters, and in the incredibly tight tolerances of shoulder kinematics, a few millimeters of elongation means the superior restraint is completely lost. The humeral head migrates back up, the impingement returns, the pain returns, and the procedure has failed clinically.
However, there is a highly reassuring clinical pearl for you listening, hidden within these somewhat sobering failure rates. A failed SCR is not the end of the line. The literature clearly states that performing an SCR does not burn any bridges for the future.
That is a critical point to remember.
It does not preclude a later uncomplicated conversion to a reverse total shoulder arthroplasty if it fails. You have not compromised the glenoid bone stock, and you have not sacrificed the deltoid.
That is the ultimate safety net of the procedure, and it is a crucial point to emphasize during the consent process in the clinic. If you put in a dermal graft and it stretches out at year 4, the anatomy is still entirely amenable to a standard primary RTSA.
The bone is still there.
Exactly. You just go in, remove the graft remnants, and put your base plate right over the previous anchor holes. You haven't ruined the joint for the definitive salvage procedure.
But I am going to seize on that exact point because it returns us directly to the core mission of this deep dive. If we know going into the operating theater that the complication rate is non-trivial, the cost is immense, and we can always convert to a reverse total shoulder arthroplasty later, does that fundamentally prove that SCR is merely a bridge procedure for younger patients rather than a final destination?
Are we just buying time?
Exactly. Is the SCR just an incredibly expensive, technically demanding stalling tactic to avoid a joint replacement?
Synthesizing the medium-term data, I believe we have to fundamentally reframe our definition of success with this procedure. Is it a final destination? For the vast majority of patients, probably not. Eventually, the native cartilage will wear out or the graft will fatigue.
So it is a bridge.
But if we view it strictly as a bridge, we must measure the length and the value of that bridge. For our 52-year-old laborer, buying a decade is a massive, life-altering clinical victory.
It really is.
It allows them to continue working through their peak earning years, providing for their family, without the functional lifting restrictions and the catastrophic component where risks of putting a reverse arthroplasty into a heavy laborer. Deferring a joint replacement for 10 years in a young, active patient is orthopedic gold.
A decade of heavy labor without a prosthesis is a massive victory.
Exactly. However, apply that exact same logic to a 75-year-old patient with an irreparable tear and mild arthropathy. For that patient, buying time is nonsensical.
They don't need to buy a decade for heavy lifting.
The SCR becomes an unnecessary, painful, extended, and expensive detour on the way to the arthroplasty they should have received in the first place. The predictability, the lower cost, and the rapid recovery of a reverse arthroplasty in an older, lower demand patient far outweighs the biological idealism of an SCR. So whether it is a bridge or a destination depends entirely on the demographic terrain you are crossing.
That perfectly encapsulates the nuance of surgical decision-making. We aren't just treating MRIs, we are treating the patient's timeline. Let's rapidly distill this extensive discussion into membrane clinical pearls for you to take back to your clinics and your theaters tomorrow.
Always good to summarize.
First, regarding the biomechanics in the graft. Thickness is critical. Biomechanical studies unequivocally show that 6 to 8 millimeters is the optimal graft thickness to depress the head and restore the fulcrum without overstuffing the joint and ripping out your anchors.
Second, the graft material dictates your morbidity profile. You must be aware of the dermal allograft's higher medium-term failure and elongation rates, but you have to balance that against the severe, undeniable donor site morbidity associated with the fascia lata autograft harvest. There is no perfect material yet. It is a shared decision with the patient.
Third, the absolute non-negotiables for patient selection. Do not push these boundaries. An intact, fully functional deltoid engine, a competent subscapularis anteriorly, and absent or minimal glenohumeral arthropathy. If these criteria are not strictly met, the SCR will fail.
And fourth, while the procedure is technically demanding, requires immense patience in theater, and the failure rates are non-trivial over time, it remains a highly safe biological bridge. It does not compromise the glenoid bone stock or the deltoid, allowing for an uncomplicated conversion to a reverse total shoulder arthroplasty if and when it is required.
Which brings us to a final paradigm-shifting thought to mull over before we close. It is something that continues to challenge our reliance on imaging over clinical presentation, and it highlights just how much we still don't know. We see this phenomena in the follow-up clinics all the time.
The asymptomatic failure.
Exactly. You order a routine post-operative MRI at 2 years for an SCR patient. The radiologist's report reads, complete mid-substance failure and elongation of the dermal allograft. The graft is functionally radiographically torn. Yet the patient is sitting in front of you with zero pain, actively elevating their arm to 150 degrees, absolutely thrilled with the outcome.
It happens more often than you'd think.
If the MRI shows a structural failure, but the patient reports excellent pain relief and maintained function, did the surgery actually fail? Or did the graft simply act as an effective, temporary biological spacer, just long enough to allow the shoulder to auto-rehabilitate, rebalance its force couples, and find a new kinematic equilibrium?
It is a humbling observation. It suggests our understanding of the human body's capacity for compensation is still deeply incomplete, and that biology often beautifully defies our rigid mechanical expectations.
It certainly does. We are just the mechanics. The body does the real work. If you found today's clinical evaluation valuable for your practice, please take a moment to rate and share Deep Dive Ortho with your colleagues.
The landscape of shoulder surgery is constantly evolving, and critical analysis of our clinical outcomes is the only way we move the field forward.
Keep questioning the consensus, advancing your clinical practice, and remembering that sometimes a collapsed vaulted ceiling can still be supported if you find the right bridge. Until next time.